Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Today we have a special guest with us. We have Dr. Paul Spiegl, who's an orthopedic surgeon who specializes in foot and ankle care and treatment. And today we're going to talk about the different things that affect your feet and your ankles, as well as how diabetes can affect your feet and how to protect your feet if you should have diabetes. I'm also excited to tell you that today I have a co-host with me, Mr. Cameron Pruse. Cameron, thanks for joining me today.
Thank you for having me.
I thought we'd shake it up a little bit with me having a guy co-host. So looking forward to having you today, Cameron.
I'm excited to be here.
Dr. Spiegl, welcome.
Thank you.
Thanks for joining me. So tell me a little bit about you and your practice and how you got into orthopedic surgery.
My background was actually in engineering and physics, so I like the mechanics of orthopedics. I like the mechanics of the skeleton, the way things are balanced, the way things are made to provide propulsion and lifting and stability. And the foot and ankle lets us use our hands. It's a very specialized organ.
You know, it's funny because I've heard that before, that doctors are like construction workers of the body. So it's funny that you say, I had a background in engineering and decided to become an orthopedic surgeon. But truly, that's what you're doing. You're looking at how things are pieced together and how you can fix them and make them stronger and last longer, right?
That's correct.
So it all goes together. And who do you work for?
Well, I am working for Perimeter Orthopedics. It's a practice in North Atlanta on the St. Joe's campus, St. Joseph's Hospital of Atlanta. And that actually corresponds to the medical center stop on MARTA.
So people can walk, take the train, and get to your office.
Yes.
Is there more than one office?
Just the one office.
Okay, great. Okay. The reason I ask is we air in Arizona. We also air in the Gulf Coast all the way out to New Orleans. So, folks, if you're listening from another market other than Georgia, please stay tuned because we're going to talk about everything that you need to know about the foot, the ankle, and if you have diabetes, do not turn that station because there's important information to hear about today. So get your pen and your paper and your coffee or whatever it is that you like to drink, and we'll get started. So, Dr. Spiegl, what are the top 3 things that you see as an orthopedic surgeon specializing in foot and ankle care? What do people come to see you for? Predominantly?
Well, predominantly they come because there's pain. That would be the biggest thing. If they have pain, and there are many reasons for pain, but basically if it hurts more than a few days, there's something wrong and it should be checked out. They might also see me because they have deformity. One foot doesn't look like the other after an injury, or it just seemed to develop that way. They woke up one morning and the 2 feet aren't quite the same. And a third thing would be that they can't do the things they want to do. And it might be dancing, it might be running, it might be playing soccer, but they can't do the lifestyle that they want to have.
And it could be something they just wake up in the morning and all of a sudden it's there, or it could be something that gradually gets worse over time.
Exactly.
Okay. And the reason I'm asking, it's not always about me, Cameron, even though I know y'all tease me that it's always about me. But I do have heel pain, and recently I've been walking, and I've lost a lot of weight, and I've been exercising and trying to go from couch to 5K in 8 weeks, according to the program I have on Facebook anyway. I'm supposed to be able to do that. But my heel hurts. But you know what? I'm not going to go to the doctor. I'm a terrible patient. So I bet that you have a lot of that. It's either plantar fasciitis or whatever else it is that I don't know, but I look up on the web. So can we talk about what kind of pain that is and how important it is for people like me to go and see you and the repercussions of not?
Yes, well, it's a matter of judgment to a degree. If it's just not getting better, but you can tolerate it, it's not really swollen, it doesn't look differently, you haven't had a major injury, self-treating is probably okay, and the internet probably okay. We can never say it's absolutely all right, and I do see people coming in who've actually broken the heel bone. They fractured it, and they didn't know it, and they kept going, and it's possible that it is a more severe thing, and there is some risk with not getting it checked out.
Mm-hmm. I'm better now, but for a long time, I'd wake up in the morning, I couldn't even put my heel down on the floor. And I didn't know if it was plantar fasciitis or a heel spur or whatever. Is that your specialty or not really?
Yes, I take care of that a lot.
And so is there a harm in it turning into the other if you're not taking care of it? When should you go see you?
When it's really bothering you, when it seems to be getting worse rather than better, and If you have significant swelling down there, if it keeps you from doing things, if it hurts for a few minutes, probably it's plantar fasciitis. And if you get through the rest of the day okay, then that's not necessary to be seen. But if it just bothers for weeks and into months, then you have to get back looked at.
And what can you do for someone who might have either one of those ailments?
It's kind of interesting. A lot of people think there's a heel spur there, and years ago we thought that's what caused it, but really it is plantar fasciitis. A spur develops in some people. It's quite common, maybe as much as, say, 20% in a middle-aged population. But most of those people don't have any heel pain, and it's really the plantar fascia, which is a ligament that holds up the arch. It goes from the heel to the base of the toes, and that supports your arch, and that's what gets painful. You may or may not have a spur. We don't have to take the spur out. We treat the plantar fasciitis. Usually it's with relative rest, say riding a bike instead of jogging, stretching exercises. We do orthotics that go into the shoes that support the arch so there's not such a strain on that ligament. Physical therapy is helpful. We don't like to do cortisone shots there because it could lead to a plantar fascia rupture.
See, that's what I've heard too. Everyone's like, oh, you need to go and get a cortisone shot. It must have been a popular way to fix problems in the past. But I had heard from another orthopedic surgeon who said, no. There's too many things that can go wrong down there. Is that right? Or?
Absolutely right. In fact, it happened to me. I had plantar fasciitis many years ago, and I had a cortisone shot and it ruptured my plantar fascia.
Oh, no.
And my arch dropped. It's not really something you should have there. That's one of the places we don't do cortisone shots.
Okay. Well, that's good to know. Good information for the folks out there. Cameron, you have anything on heel spurs and plantar fasciitis before we move on?
I did have a question about some things our listeners can do to avoid the pain, to deal with the pain without having to come see you right away.
Well, stretching exercises for the heel cord are important. The runner stretch, where the heel cord is stretched with the knee straight and then with the knee bent. Hold that for 30 seconds in each position. It's important to walk around or get a little bit of exercise before you do the stretches. If you do a stretch when you're really cold, you actually could hurt yourself more than you help yourself. Icing is helpful. The anti-inflammatory medications over the counter help you get through the pain. It doesn't really make it heal faster, but it helps you get through it. 99% of the time, or maybe 95% of the time, it will go away on its own without intervention. We don't usually have to do anything more extensive with it than that. Just rest it. Don't do the things that are aggravating it.
What are some other ailments that people come in to see you for that we want to educate our audiences on?
Well, people come in with strains of a lot of muscles. They come in with sprains of a lot of joints. They can sprain their instep. They can sprain their toe joints. And many times, just with day-to-day activities, particularly as people are more active, it seems to be happening more than it did when I first started practice back in '83.
The good news is I do think people are getting more active. I don't know if it's just my age. We hit midlife and we say we better get up off the couch, but it seems like most of the folks I know now versus the folks I knew when I was raising babies, I guess, we're getting out there and we're getting moving and we're doing 5Ks and we're participating in life a little bit more. Would you say? Or?
Yes, I totally agree. And I think there's been a big change because it seems that when I was in my 20s, I'd look at people in their 60s and they'd be retiring, where now a lot of the time these people are fit and they're energized and they're really in their prime yet.
Well, that's good news. But then I get into trouble because we get out there, and I'm not speaking about me, I'm speaking about all of us because everybody's got to do this too. We get out there and we decide, okay, we're going to get fit. And we don't do the stretching properly. I see people, they come out of their car and they get on that trail. I don't see a whole lot of folks stretching. And I think that's probably where we get into the most trouble.
Yes, and we have to be realistic too. We can't go from doing nothing to doing what we'd like to do overnight. Right. We have to build up, and we have to be a little more patient than we were when we were in our 20s, and we could just jump out and run like that.
I noticed, and you didn't know I was going to be asking you about this, so I apologize, but I noticed that you are an author and that you wrote a book on skeletal aging in premenopausal women. Do you want to talk a little bit about that? What did you find?
That was interesting.
Because, of course, it is about me, Cameron. I'm sorry, Dr. Spiegel, go ahead.
Sure. At the University of Wisconsin, they actually discovered vitamin D, and it's the dairy state, so they were really big into calcium and vitamin D and, of course, skeletal issues with the calcium and the way that the skeleton deteriorates with time. We studied what happened to people over a 2.5 year period and looked at how the bone would weaken with time. We could see a difference. They actually also developed many of the scanning techniques that they do for skeletal osteoporosis. So that was what we used to study it. Smoking was a bad thing. Taking hormones was a good thing. And there were genetic factors. Otherwise, exercise, we couldn't really tell on. It was too short a period of time to study that.
Yeah, like I told you, I had recently lost weight and gotten healthy. And one of the things that my weight loss coach had said to me is you must drink a glass of milk every single day. As a middle-aged woman, you must drink a glass of milk every day. And they were sticklers on that. Every time I came back in, they were checking to see if I got my milk in every day. But, you know, I did have a vitamin D deficiency. And even though I was healthy and drinking the milk and all of that, do you suggest that women take vitamin D supplements?
I think it's a good thing to do. And really, the calcium really need to get more than 1 glass of milk. And, you know, you can take the over-the-counter supplements. Tums has 200 milligrams, but you want to get at least 1,000 milligrams. Milk or a serving of cheese has about 250 milligrams. So
yeah, I have no problem getting the cheese in.
4 servings of a dairy product or supplement with over-the-counter. Vitamin D, probably 2,000 units is what we need. It's surprising. We do find that a lot in people with what we're going to be talking about later, the wound healing problems. They're vitamin D deficient, or people that don't heal their fractures. We'll test them and find out vitamin D is deficient. You know, these are healthy people doing regular activities, regular jobs, and you'd never imagine it.
Yeah, I was surprised. But again, too, and I know we're going to talk about foot and ankle, but as a woman, you really have to go out and get the vitamins that are geared towards you as a female, not just a vitamin off the shelf, because they are going to adjust the different types of vitamins that the female body needs. So again, just a little bit of shout out there to make sure that you get a vitamin specific to women. Okay, so let's talk about the foot and ankle. How are feet at risk of becoming deformed?
Well, of course, it can be an injury. That's, I think, what most people would think of, where they twist their ankle or fall down the stairs or something of that sort. But then there are the gradual things that happen, day-to-day activities, overuse, and with that, a joint or a tendon or ligament just gradually deteriorates. The ligaments are what hold bones in alignment. The tendons are what go from the muscle to the bone to give it direction and give the foot balance. But at any rate, these structures, each of them can deteriorate with time, just a little bit at a time, kind of like a rusting hinge.
And what can we do to prevent that from happening?
Well, I think we have to have regular, appropriate exercise, do the stretching.
Keep the ligaments in shape.
Yes, a good diet. I think it's important to, as much as possible, maintain a healthy weight for the body, for the particular skeleton. And that seems to be with time that we have to decrease our weight a little bit as each year goes by, a pound or two. But anyway, those things are helpful. Wear sensible shoes and do things on a more of an even keel, not sprints and spurts unless you work up to that, but regular medium impact activities.
Okay, we have to talk about something, and I know I'm not going to like the answer. Wearing sensible shoes. So I'm taking it all those really cool, pretty high heel. I really like the 3.5, 4-inch heels. That's not going to work for me, huh?
I don't touch that. I don't tell people not to do things, whether it's running 100-mile races or wearing high-heeled shoes or what have you.
Okay, good. We can continue.
It's always important to look good, right?
But I guess that would be a precursor to some foot issues.
It tends to aggravate the foot issues. We know there's a big genetic component to a lot of this, too. Typically, if someone is going to get a bunion, for example, it's a big genetic component. If they're going to get a bunion anyway, the dress shoes may aggravate the symptoms. It may make it go faster, but it's a big genetic role. And
so if you're going to get it, you're going to get it. You might as well wear the pretty shoes until you go for the surgery, right?
Well, I might not go that far.
But they do aggravate. And that, I was going to bring up bunions because that is It seems to be a trend in my female friends at the moment. And I don't know if it's the high heels or just all my friends have that genetic issue. So let's talk about bunions, because I bet that's a real common issue for people that come and see you.
It is, and the thing I would say about it is our treatment of bunions has evolved over the years. As I mentioned, I've been in practice since '83, so when I was first in practice, it seemed that we would tell people, and men get bunions too, just
That's
not as
true.
often.
This is not a female show. I'm sorry.
Yeah.
Cameron, we need you to pipe up a little bit more. I'm taking over.
Yeah. At any rate, many times patients come in to me now and they say, well, 10 years ago, my doctor told me, or 15, 20 years ago, that I should try to live with this until I just couldn't stand it anymore. And just like anything else that you let wear and tear and deteriorate, things are so bad then that it's hard to get the results that we want. It could have been so much better if we'd fixed it sooner.
Because you hear that's such a painful surgery.
Well, we have improved the surgeries. Both the surgical techniques have evolved and anesthesia techniques, and so it's not nearly the painful thing that it used to be.
So what's the turnaround time for recovery for someone who came in? And I know you're going to say it depends on how long they waited to come see you.
Well, it depends on that. It depends a lot on how severe it is, because there's really a wide spectrum of problems with the bunion. Just looking at it, people think that it's a growth, but it's really not. It's like if you look at your elbow and you bend your elbow and you see this bump come out, that's what a bunion is in the other plane. It's the joint sticking out. So I have to realign the bone, and it depends on how severe it is. It's like saying, well, how long will it take to fix my car? And I have to say, well, what's wrong with it?
Right. I guess that's true. But I do think people are waiting too long to get that taken care of.
Yes.
So let's help the listeners. And I know you can talk about pain, but sometimes it goes away and then you forget about it and then it comes back. So when's the right time to come and see you? I mean, before the toe is crooked, I'm sure.
Yeah. Well, I think if the toe is starting to turn so that the nail is pointing to the side, that's important to get it evaluated. The other thing to look at is it starting to affect the other toes, like the toe alongside of it? Is it going under that or over that? Is that toe starting to get deformed too? So if we're seeing these things, it's certainly getting more advanced. If the toe is stiff also.
Okay. And then I know I talked about this, but I don't recall what you said. The turnaround time for recovery, typical. They take time to heal. Probably I would protect the person, I would say kind of middle of the road would be 3 or 4 weeks. I Wow.
usually use a foot cast because I find that really holds it, protects the tissues, protects the foot, and lets the person walk on it. But that's an inconvenience, to say the least.
And that's before they go back to work. Really, they're going to need 3 or 4 weeks at home?
Well, no, they're up moving around, walking around, and they could, of course, depending on their work. If it's a sit-down job, I would say within a week. We do have problems with swelling, and we do want to keep the foot up in the first several weeks, keep it up as much as we can. But if someone has a job, they say their work is a nurse in a busy emergency room, and they're running from room to room, it's going to be several weeks before they're back there.
And that's probably another reason why people wait too long to get it taken care of.
Yes, unfortunately, feet heal slowly compared to, say, a knee or a shoulder arthroscopy.
And I want to talk more about that because the feet, that's your life. If your foot's not working, you're impaired. You can't get around, you can't do anything. And so I think it would put us at risk for other factors if we can't get up and get moving and all of that. So let me ask you, why are foot problems a big risk more than other body parts?
The foot just heals more slowly. That's one of the issues with it. We can't rest it like we can rest something in our upper extremity, some shoulder, elbow, hand, because we need both feet. And, realistically, if we walk a mile, we have thousands of foot strikes. And, many times we walk more than a mile, several times a day even. And people who are, busy at stores, busy traveling, going to Hartsfield Airport, walking around the malls. So that puts a lot of strain on the foot. We can't rest it. It swells up. It doesn't heal quickly.
Well, great information for folks. And do you want to just give your contact information if folks have questions or want to get in touch with you? How can they reach you?
Yes, I'm at Perimeter Orthopedics in Atlanta. That's 5673 Peachtree Dunwoody Road, Suite 825, Atlanta 30342. And our office phone number is 404-255-5595.
And if folks just wanted to look up common foot and ankle problems or check out your website, can you give them your website for me?
Our website is www.perimeterortho.com.
Okay, great. Well, thank you so much for being here. If you have any questions, please contact Dr. Paul Spiegel, or you could also contact us at the Hope Foundation, and we'll get you connected with any one of our guests. Okay, well, thanks, Dr. Spiegel. For you folks listening, we'll be right back after this quick break to hear more about diabetes and how to care for your feet. Important information to come, so stay tuned. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Welcome back. Thanks for staying with us during our quick break. Again, I'm Jeannie Pete. You're listening to Better Living, and I have my co-host here with me today, Cameron Peruse.
Hello, how you doing?
Thank you, Cameron, for coming and joining me today. It's nice to have a friend and a friendly face on the radio with
Thanks for having me.
Not too much teasing over there from the peanut gallery.
Just wait.
Again, for those of you who have stuck with us through the break, we are here with Dr. Paul Spiegel, who is an orthopedic surgeon, and we've talked a lot about foot and ankle care and some of the typical ailments like bunions and heel spurs and plantar fasciitis in the feet. In this half hour, we're going to talk about diabetes and how and why feet are very important in the care, in your physical care if you suffer from diabetes. Dr. Spiegel, do you want to talk a little bit about diabetes and how it affects the foot and ankle?
Well, diabetes is a common problem, and the way it affects the foot and ankle is that it causes a peripheral neuropathy. Now, there are actually a lot of other causes for peripheral neuropathy, but I would say well over 85% of the people that I see with peripheral neuropathy are diabetic people. What I mean by neuropathy is that the nerves to the feet aren't working properly. And the most obvious thing that one would think of with this is that people lose their sense of touch, and many times they don't realize it, but when it gets to the point that they lose their protective sensation so that they could, for example, step on a tack and not realize it, then they're really at risk.
Now, do you find that that may be the symptom that helps diagnose their diabetes, or they have the diabetes first and they come to you because it's gotten worse? You know, because you hear about the tingling, or what do they say if it feels like you have ants?
Yes, that may be the first symptom. It's not uncommon for me to see people that come in with a cut that didn't heal, or they didn't notice they had a cut for several days or more, and we do some tests and we find that they're diabetic. So it's not uncommon, although in my practice, which is more referral, I more typically see people that are already diagnosed.
So for folks listening, if you're having problems with your extremities, not just your feet, your hands too, right, Dr. Spiegel?
Yes, it involves the hands too.
Right. And is it tingling? See, I have a thyroid condition, so sometimes I have the tingling and the numbness, but that's not diabetes. So I'm just trying to help our audiences be more alerted to, hey, I might need to go to the doctor and get checked for diabetes. So let's help them.
Yes, I think it's important to get regular checks, like an annual check with the primary care doctor. But a thing that can alert someone would be if, for example, they step on something sharp and it doesn't feel sharp, or they don't feel the texture of the carpet or the sand, those types of things. It should be investigated.
And what is it that they say about the ants? It feels like you have ants crawling on your feet. Is that correct?
That could be one of the symptoms. Many times they feel a burning sensation.
Burning.
And that can be really severe pain in some instances. And then some instances it's just nothing at all. I didn't know, I couldn't feel that. And they come in with a cut, and that's why it doesn't heal.
And that's the nervous system being affected.
Yes.
Is that what diabetes does? It affects the nervous system?
Diabetes seems to affect the small nerves by affecting the circulation to those small nerves. It affects the blood flow to those nerves, and the nerves then become unfunctional. And it affects not only the ability of the limb to feel, but also it affects all the muscles, there are 13 muscles in the foot, and these get affected. So the patient develops hammer toes or other deformities, and it also affects the skin quality. It affects the blood supply to the skin, and it's through the autonomic system, we call that. So, for example, it makes the skin moist, it makes the skin sweat, it makes the skin blush, and that function is lost. So the skin loses its circulation, it becomes brittle and dry
And cracks and
Cracks
sometimes
and-
can bleed, right?
yes, sometimes that ulcer starts with a simple cracked skin and no injury at all. It just started with that, and it goes on for months.
And then when you're a diabetic, it affects your ability to heal. Isn't that correct? And so
Yes.
then you can't get rid of the wound.
Right, because there's poor circulation in the area of the wound, because of, again, the nerve problem. Also, there's deformities. If there's a hammer toe or a bunion that develops because of muscle imbalance, and then there's a bone prominence, and so that's hard to heal that skin over a prominent bone. And then probably the worst thing is that they don't realize that it's injured. When something doesn't hurt, everyone thinks it can't be too serious. And for someone who has the diabetic problem, they're misled by that to think this isn't serious because it doesn't hurt, and it's really their loss of feeling.
And then they could get infected.
Then
and then
it-
it could
yes,
get
then
into
it
their
gets infected
bloodstream
and-
and they
yes.
could get very sick. And that has happened. Well, I was reading, thank you for all of the information that you gave to me today, by the way, to prepare for the show. But I was reading one of the articles you brought in. According to the American Diabetes Association, about 15.7 million people, which is 5.9% of the United States population, have diabetes.
Yes.
6% of the United States population, that's a lot.
Yes, and there's another 7 million or so that are not diagnosed as having, they have it, but they don't realize it. And even besides that, there's another 79 million that are pre-diabetic that are likely to develop it in the near future.
And we hear with one of my favorite shows, The Biggest Loser, I got hooked. That's actually what prompted me to get healthy the first year. I moved the treadmill down to the living room. But seriously, you see folks coming in with all kinds of health issues, and a lot of times diabetes is one of them, and they get healthy. They get moving, they eat well, they take better care of their bodies, and they can actually, I don't know if they can actually get rid of the diabetes.
I think if you have it, you always really have the diagnosis. You have that tendency. You know that genetically you're destined to have it if the weight goes up. But many people can put off those symptoms if they keep their weight down, stay active, eat the right foods. In other words, not a lot of sugary foods or starchy foods that really kick the blood sugar up. Then they can put that off for a long time. Put off getting diabetes for a long time, or reverse it so they don't need to take meds for a long time.
It's amazing to see the transformations of these folks on these shows, and if they're on exorbitant amount of medications to take care of their health issues, how many they're able to get off of when they get healthy. And folks, I was a couch potato. Your typical woman with a full-time job, taking care of children, trying to keep house and home, and who do we not take care of? Ourselves. And I see it a lot, and now I'm trying to get out there and motivate other women in their middle age to get moving and take care of themselves and put themselves first. But it's very important, no matter what your age, just start walking. It might start with not even a mile. Just get up and walk your neighborhood, and then make it a competition with yourself. I can do this 2 days a week, or I can only do it on the weekends in the beginning. And then you start to feel better, and then you can do it 3 days a week, and then maybe you can do it 5 days a week, or else instead of a quarter of a mile, you can go a half a mile. Instead of a half a mile, you can go a mile. Because once you get to Dr. Spiegel with these diabetic ulcers on your feet or the neuropathy that he's talking about, it's a lot harder to get moving because your feet hurt. Or maybe they don't hurt, but they're infected and they're making you not feel good, right, Dr. Spiegel?
Yes, or we have to do things to protect the foot so it heals, so we can't let the people walk. And so it has all these reverse health implications then.
The show is called Better Living, and there is a common thread, as I'm so blessed to be able to host this show, Dr. Spiegel. And you too, Cameron. I'd like to hear a little more from you over there, Peanut Gallery. But every time I interview someone and learn more about the many different topics that I am fortunate enough to learn about while I'm trying to educate the communities, there's a common thread. And it is take care of yourself and take care of your body. There are some things that are out of your control. There are some health issues that you have that you can't help but have. But if you get yourself moving and if you make choices to eat something different that's low in sugar, you're helping your body and you're going to have better living, which is the whole point of this show. So I'll get off my soapbox now and we'll get back to talking about you, Dr. Spiegel, but I'm more and more passionate about it every week as I talk to orthopedic surgeons and oncologists and neurologists and physical therapists and everyone else who's been on my show. The common thread is do what you are empowered to do to take care of yourself so that you can lessen the risk of getting diabetes or having injuries, and stretching, even just as little as stretching. Just take care of your body.
One thing that I'm interested in hearing from Dr. Spiegel is, we talked about preventative measures for diabetes, but let's talk about what people can do to take better care of their feet if they already have diabetes. What can they do to take steps to prevent the ulcers? We spoke about the cracked skin and things like that. What do our listeners need to do to prevent these ulcers from occurring?
It's important to inspect the feet every day. What they can do is, if they don't have anyone to see the bottom of their feet, because it's just not possible for them to see the bottom of their feet, they can use a mirror to look at it, and they should not walk barefoot. They should feel their feet too, because if the foot becomes hot or red, something's going on inside too, and they have to be suspicious there's a problem. If one side's not like the other, is indication there's something going wrong. They should be careful to wear shoes. They should moisturize their skin every day, make sure the skin doesn't get dry and cracked. Wear shoes that are appropriate for them. Particularly if there's a more advanced neuropathy, we get protective shoes and protective insoles in the shoes so that they're not likely to get blisters or get pressure areas.
I'm happy that you said shoes too. What kind of special socks and shoes can help prevent these things?
I think that a shoe should be like a rounded toe, well padded. Athletic shoes are very good, walking shoes. Socks are important just in terms of keeping the moisture away. There's some help with, say, cotton. I just happened to blank on the synthetic that really wicks away the moisture, because we do want moisture to be wicked away so that there's not maceration.
You have some basic advice for taking care of your feet, and I was reading some of them. Always keep your feet warm. Don't get your feet wet in the snow and rain. Don't put your feet on radiators or in front of the fireplace. Don't smoke or sit cross-legged. I'm in trouble with that one. And wear loose socks to bed. That's tough. I can't stand socks on my feet.
Yeah.
And why is that? Just to keep the moisture out?
If the skin is dry and cracked, then put a moisturizing lotion on there and wear the socks, because otherwise it's dabbed off in a few minutes in bed. So
we're okay not to wear socks if our feet are not dry and cracked.
Yes, as long as there's not those issues. But when that happens, we do have to do the moisturization and wear the socks, yes.
One topic that I know that Jeannie's going to love is trimming your toenails and treatment of your toenails and things like that. What steps do our listeners need to take to, ensure that they're not cutting themselves or anything like that?
It's very hard for the folks with advanced diabetes to do that. So having someone, a family member, or to go to some individual who provides nail care to do that is important. Cut the nails right across, not curved like a fingernail, but straight across so it doesn't cut into the cuticle. Unfortunately, as people get older, they require somebody else to do it because their vision isn't as good and they can't flex their body to get down and really see what they're doing. So they shouldn't do those things. And if they get an ingrown nail, they shouldn't do bathroom surgery, as we call it.
What do you do for ingrown toenails?
If it's not too severe, we can treat it with topical antibiotics and antibiotic soaks. And we do a Clorox and Epsom salt soak and oral antibiotics. If it's really lacerated the skin and really red and swollen and draining, then we actually take the corner out and it grows out.
Oof.
It takes about 6 months to grow out a nail, so they can put a little wisp of cotton in between the nail and the fold of skin until the inflammation settles down.
Cameron's right. This is not my favorite topic. I have a hard time with all of that nail pain in your toe. Luckily, I've never had an ingrown toenail, so I just don't know what to even imagine there. So. But cut the nail straight across, because that's what will cause the ingrown toenail, and then get on top of it as soon as possible, as soon as you feel some pain, Because if it gets away from you, then that's when you get, I don't want to talk about it
Yes.
again, but that's when you're going to have to go in and,
Right. Or for the diabetic folks, check it every day to see that each toenail is good and that there's not a crack developing between the toes. Really inspect it.
well, let's talk about that then, because if somebody has diabetes, they really want to take very good care of their feet, not let it get away from them. Do you recommend they go to these nail salons and have these pedicures, or can that cause more harm?
That's variable. There's such a wide variety, and they have to be sure that they're getting good care there. Many places have people that are dedicated in their office to doing nail care. We have a few people who do that. That's not a big part of our practice, but people can come to our office and have the nails cared for every 4 to 6 weeks, something like that. Nail salons, some are good, some are not so good. Even for people without diabetes, sometimes they get cut and get into trouble with these pedicures.
I would imagine it would be good because it keeps the feet moist. It keeps it from, because they do put some great lotions on there that do last for a little while and keep your feet soft and healthy.
But with diabetic neuropathy, when it gets advanced to that point, and it doesn't always start out with the neuropathy, but as the diabetes has been there for a long time, it does become so that the skin tends to be dry and cracked, and it needs daily moisture, and that's when we go with the night socks.
Yeah, I'm going to avoid that. Okay, great. Prior to you coming in, Cameron and I were talking about some of the paperwork that you had given us. I'm going to probably massacre this name, but what is Charcot foot?
You said it right. Charcot was a neurologist in France, and what this corresponds to actually is a disorder that's associated with neuropathy, and the bones actually break without any significant injury. And once this process starts, the bones will shatter, not just one bone, but several bones, and there will become a deformity. We know this is happening because the foot becomes red and swollen. For example, the arch might drop overnight.
Is it related to people with diabetes, or it could happen to anyone?
It could happen to people with neuropathy.
Okay.
It wouldn't happen otherwise.
That sounds extremely painful. What can our listeners do to see if something like that is happening? I mean, I'm sure pain is going to be the first sign, but...
Well, no, actually, pain isn't the first sign. Only about half of the people find it painful. And that's usually after the process has developed. But it's something that is really hard for a non-medical person to understand. But because there's no feeling there, the bone becomes injured and the ligaments around the bone become injured. And so the joints actually shatter. It's worse than if they had fallen off the 5th floor. The bones become very weak. So the point is we try to catch it before it gets so advanced. And if we come in and the bones are in 100 pieces, there's not too much we can do about it.
So would you say weakness is the first major sign?
Warmth and swelling or deformity.
Warmth and swelling. Okay.
Wow, so people could not have any pain, not realize anything's wrong, and they come and see you, and you tell them they have these Charcot fractures, and then there's nothing that you can do about it. And then they have a hard time walking from then on in?
Yes, well, if we catch it before it really becomes deformed, because it's not necessarily all or nothing. Sometimes it seems to be that way.
Wow.
But for other people, it will begin with swelling, and we'll get x-rays, we don't see a thing. We'll get a bone scan or an MRI, and we see that the process we suspected is going on. So we protect them with casts and keeping off their feet, and with time it can heal. It could take weeks or even months for that process to heal, longer than a regular fracture.
Wow. So it is so important, folks, to check your feet every day, especially if you're a diabetic or if you have neuropathy. What might be some instances where they'd have neuropathy but not be a diabetic? Just after an injury, or?
It could be after an injury. That's not so common, but that's possible. People with myelodysplasia, with some of the rheumatological conditions like lupus or rheumatoid arthritis. In my practice, there's probably 7 or 8% of the people with neuropathy have idiopathic. It's
have what? I'm sorry?
Idiopathic.
Idiopathic.
Yeah, big word, sorry. That means we have no reason to explain it. It just happened. It's like getting, say, a cancer. We don't know why it happened. It just developed. There is some hereditary components to that too, but there are other people that just seem to develop it. Just notice it sometimes as early as the 20s or 30s.
Well, this is great information. You know, I'm not diabetic. I really don't know too many people who are diabetic, but the folks that I do know who are diabetic, the feet are a huge issue for them. And so if you are suffering from diabetes, or if you notice something going on with your feet, go and get checked. Because like everything else, and I'll get off my soapbox about getting healthy, but go to the doctor early. Have your annual physicals like Dr. Spiegel spoke about earlier, because the sooner you catch health issues, the more able the doctors like Dr. Spiegel are to help you. You don't want to come in with a Charcot fracture so bad that it's going to affect your walking ability for the rest of your life. What else do we want to leave our listeners with? We never have enough time, and it's almost time to end the show. The top thing that you want folks to know before we go today.
I think that it's really important to take care of the feet. It's important without diabetes or with diabetes. So just be really careful. Check your feet. Don't overdo it.
And stretch.
And stretch.
Unlike me. And don't get yourself an injury that you definitely don't need. All right, one more time. If folks want to get in touch with you, can you give us the website and the phone number for your practice?
Our website is www.perimeterortho.com. And our phone number is 404-255-5595.
And before we go, I'm just going to read our listeners again some basic advice for taking care of your feet. Always keep your feet warm. Don't get your feet wet in snow or rain, which is hard sometimes, but if they get wet, pat them dry and warm them out. Don't put your feet on radiators or in front of the fireplace. Travesty. Don't smoke or sit cross-legged. Both decrease blood supply to your feet. Don't soak your feet. Don't use antiseptic solutions, drugstore medications, heating pads, or sharp instruments on your feet. And when drying your feet, pat each foot with a towel and be careful between your toes. Buy shoes that are comfortable without a breaking in period. And check how your shoe fits in width, length, back, bottom of heel, and sole. We're not going to talk about avoiding pointed toe heels and shoes and all of that because Dr. Spiegel told me earlier in the show that it would be okay for me to wear those. So I'm Jeannie Pete. Thanks again for listening. Dr. Spiegel, thanks for joining us on the show today. This was a great show and great information for our audiences as we talk about 5.9% of the U.S. population suffering with diabetes. Important information to get out to our listeners. So thank you so much for coming.
It's been my pleasure.
Cameron, it was fun. Thanks for joining me today.
Thank you for having me.
Until next week, folks, I'm Jeannie Pete. Have a great week.